Now I request Dr. Soumya Nambiar to talk on the right anesthesia, local, general, and the workup of these anesthesia. Over to Dr. Soumya.
Thank you, ma'am.
Soumya is the consultant pediatric ophthalmologist in Contrast Eye Hospital. She did her fellowship in Shankar Nethralaya, Chennai.
Thank you, ma'am, for that introduction. So basically, we being a pediatric ophthalmologist, we cannot go without an anesthetist. We have to have a teamwork and we need their help at every stages of our surgeries. So as a novice strabismologist, we need to decide what is the right anesthesia that we have to choose for our surgeries. And it differs, or the basis depends upon where you're working. Maybe a private institute or a private setup, or it may be an institute. So you have to decide. So basically, the various types of strabismus which we know are horizontal and oblique surgeries. So therefore, the type of anesthesia will depend upon what type of patient it is, what type of strabismus, and how many muscles you're going to tackle with, and is the surgery done for the first time, and the doctor and patient confidence level and the availability in your place. So the options of anesthesia is the local anesthesia. Local anesthesia, usually when you do, if suppose it is as a beginner, you have to start with a peribulbar block. You can do it in cases of unilateral cases, a simple R&R, a recession and resection. You can also do in bilateral cases, because if you don't have a GA setup, definitely you can opt for a local anesthesia. But definitely it's more time consuming for you as well as for the patient. He has to lie down comfortably. But before doing, rule out all high risk cases. Definitely a cost factor can be reduced by giving a local anesthesia when compared to a general anesthesia, and you require minimal equipments. Most commonly what we use is lignocaine and bupivacaine. Problem is that complete echinacea is usually achieved, but sometimes when you pull the muscle, there may be some amount of discomfort whenever you do a local anesthesia as well. Then topical anesthesia you can do whenever you're planning a single muscle surgery. If you're planning to do a FDT or FGT, Botox injection if you're planning to give. And at the time of adjustment, like an adjustable you have done, you can give a topical where if you have to do the adjustment. In minimal invasive strabismus surgery you can do. Basically, it avoids the serious complications that are associated with GA. Now, topical anesthetic techniques, whenever we use, it's better to use that anesthetic. You soak that is, you dip your vessel sponge, you dip it in the local anesthetic and keep there for some time instead of using the plain paracaine. So this is more beneficial than just putting a paracaine and then doing it. Suitable for surgery for medial and lateral rectus muscle. It should be avoided in other extraocular muscle, like you're planning an oblique surgeries and all. It will be difficult if you're doing it, and it will be uncomfortable to the patient as well. So general anesthesia is done in almost all pediatric cases, and if at all you're planning transposition, transplantation, looking for slip muscles, bilateral cases, oblique muscle surgeries, complex strabismus, and repeat surgeries. So for this, you need all these. You need the multiparameter, you need the ventilator setting, the flow meter settings. All these are the basic equipment that you will need for a GA. Then the prerequisites when you're doing a GA, a safe GA includes all this. That is, you need to have a preoperative assessment of the patient, evaluate the airway, you need to induce the patient, you need to secure the airway, maintenance, and all that. With that, you need a management of the pain and you need a recovery room. Okay, for a general anesthesia, all this is required in an ideal anesthetic environment. And remember that all this has to be recorded. As you can see on the left side, you have a general anesthesia details. So this is how we follow. We have all the details, what has been done, patient name included, what type of anesthesia, what is the in time, what is the out time. This chart has to be maintained. Anytime there is a problem, this is what is first goes into the police records. So this has to be managed and documented. So in a pre-anesthetic checkup, what we do is we have to take the history completely and check up all the systemic conditions like respiratory, cardiac anomalies, and syndromic patients. Malignant hypothermia is one thing which we are always scared of, but it has been found that in strabismus the risk is no longer there. So PAC can also be done in immediately before surgery. So in some centers, we do not have an anesthetist. So we call them for a certain time and they do a PAC just before taking up the patient for surgery. But if the anesthetist is dissatisfied, telling that there is some problem with the oral cavity, the case is getting cancelled. You will have to explain the patient, you will have to explain the bystanders, and that is time consuming, and also it is not monetarily also problematic for the patient. So these are the steps that we follow while giving anesthesia. In pediatric anesthesia, how is it different from adult anesthesia is, first you give an inhalational anesthesia and after that only you give an IV line, because the child is not going to cooperate for the IV line in the beginning. And this is how we maintain the anesthesia. That is the difference between LMA and endotracheal intubation. What is the difference? Most of the surgeons nowadays prefer a LMA, okay, that is the laryngeal mask airway. So basically what it is a supraglottic airway, okay. It is found to be safe, it is less traumatic to the patient, useful in difficult airways. When you are not able to put the tube, it is useful in this condition. And it's told that less anesthesia is required for relaxation. There's a shorter period of recovery time. While in case of endotracheal intubation, it goes through, the tube goes through the vocal cord, and therefore it requires a very good airway to put it. And this is usually used when you are planning for very long surgeries. And there will be reduced comfort level after the surgery. The patient will complain of sore throat and cough after that intubation. Though it is safe, it is definitely safe, but the shorter period of action, recovery time is little more longer. So complications that we usually dread in a strabismus surgery is the OCR, or oculocardiac reflex. So what is it defined as? Whenever there is a 20% decrease in heart rate from the baseline, or presence of arrhythmia which is induced by pressure on the globe or traction on extraocular muscles. This is how we get a OCR. So the OCR in strabismus surgery is as high as 86%, and as you can see in pediatric patients it's very high. So the symptoms are generally mild and transient in most patients. So what do you do if you have a OCR? So basically what you have to do is just immediately stop pulling the muscle, and that time it will give more time, prevent that OCR. And in cases you can also give atropine and glycopyrrolate, which tends to reduce this amount. And it's been seen that along with general anesthesia, if you give a little bit of local anesthesia, it prevents this. Now, during FDT, you have to see that saxamethonium interferes with interpretation of FDT. So always you can delay the forced action test for about 20 minutes after injection. Okay, otherwise you may not get a good result. And nowadays, non-depolarizing muscle relaxant, like what we use, the atracurium, that is more beneficial for forced action test. And therefore, on conclusion, the type of anesthesia varies with each patient and type of strabismus. Be mindful of patient's comfort and your comfort to adopt a safe practice, and documentation is definitely mandatory. Thank you.
Thank you, Dr. Soumya, for that wonderful talk on anesthesia, the basic principles.